Back to you with more of PM Agenda.
Thanks so much, Helen. And now to another key budget measure, and that is the $7 Medicare co-payment. Looking at the current Senate, which only has another 2.5-3 weeks to run, well, there's a snowflake's chance of this legislation getting through. But looking to the next Senate, could there be some negotiating, tinkering of this policy? Joining me now to discuss that is a former health advisor in the Howard government, Terry Barnes from Melbourne. Terry, thanks so much for joining me. Now, you've written extensively about this over the last couple of months and even a couple of years, I might say. Now, looking at the next Senate with Clive Palmer making up much of the crossbench, or at least his voting bloc, do you think with a bit of tinkering of this co-payment there could be some parliamentary success?
Well, I think that the co-payment package as it's currently put together is probably very dead in the water, but I do think that with the right adjustments, with the right changes, it can be made palatable, not just to Clive Palmer and his kennel of senators, but also, I think, beyond that to the Australian community. But it takes a decision, though, Laura, for the government to decide to negotiate.
Yeah, the key at the moment is that it's perceived as an unfair budget, and I think the Medicare co-payment does play into that a fair bit. Now, you've suggested, first of all, that it could be reduced from $7 to perhaps $5 or $6. How would that change the dynamic?
Well, I recommended in the paper that I did 6 months ago that it be $6, which was basically indexing the Hawke government's original 1991 co-payment to the end of last year. But when you think about it, if the co-payment was, say, $5, that's a single $5 note across the counter at your general practice. That's easy for people to understand, it's a relatively fair amount, and it's still enough of a price signal to patients to say that, look, you are contributing to a world-class healthcare service.
You've argued as well that in this structure that's been put forward, in the Abbott government putting forward this $7 co-payment, the details attached to that, the government hasn't actually addressed the structural reform issue. What do you mean by that?
Well, what I mean is that by looking for co-payments on not just general practice, but on pathology and radiology, the government has tried to maximise the savings it gets to the budget at the same time as bringing in this major structural reform of Medicare and bringing in a principle that really is overdue, that we all pay according to our means, right through the community. I think it's important, though, to ensure that it is kept as simple as possible, and I think the best way to do that is to focus the co-payment entirely on general practice services and assume that the savings will come down the track. If you try too hard for the savings ahead of the structural reform, you're just not going to get across the line as I see it.
So with targeting pathology services and the like, if someone goes to the doctor under this scheme, they'd pay $7 at the GP and then $7 to a specialist and then perhaps $7 to a pathologist. Is that what you're saying would happen at the moment? And paring that back might at least make the community realise that it is a lot fairer. You just pay one off $7.
Or $5 or $6 as the case may be.
Or $5 or $6,
but that's right.
Yeah.
If you go to the GP, say you're sick or your child is ill, and you go to the GP, you pay your $7. You go get ordered pathology, so you pay your $7 there. You have an X-ray, that's another $7. You go back to the GP, $7 again. So that cascading effect, particularly on families with lower incomes, whether they're in the concessional or child safety net or not, is a big ask. So if we can make it as simple and as fair as possible, it's harder for the critics to say, well, look, this is wrong, this is bad, and this is inequitable. It's as simple as that.
It's not passing the fairness test at the moment as you see it, but also when we talk about a broader safety net, you've argued for a one-off compensation for pensioners. How would that work, and is that effectively means testing the system?
Well, what has happened in the past with major reforms of this sort, whether it be the Pharmaceutical Benefit Scheme safety net back in the early 90s, whether it was the GST, even the carbon tax, the governments of the day put in place some compensation for lower income people, particularly those on the pension and other benefits, to ensure that they weren't badly out of pocket. Now, if, say, the pension was increased by $70, that being the current value of the proposed safety net, the 10-service safety net, then that's built into the person's income. They can sort of say, well, look, the government has budgeted for this, so I can budget for it too. But I think whether or not they reach that limit of 10 services, and many people don't, let's get that right. It's important that the government can say that we have done everything possible to keep this proposed co-payment and the basic principle intact without compromising the fairness of its application to those on lower incomes. And it's that fairness test that is important. Now, I don't think the principle is wrong. The principle of a co-payment is wrong, and not at all. I wouldn't have been out there for the last 6 months arguing for it if I thought that. But I think it's important to get the principle through and entrench it, because there's a lot of very institutionalised resistance to this, not just from the opposition, which has taken a fairly hypocritical view about attacking this proposed co-payment, but also from the medical establishment, including the Australian Medical Association. You have to crack that resistance to establish this principle.
You've spoken about the importance of having a price signal as well, not only when we go to the doctor, but also to emergency departments. Now, it's important, I guess, to have that price signal there as well to ease the pressure on emergency departments. But are you advocating that payment to be a lot higher?
Well, as this issue has come up, I have said it should be at least the same as the GP co-payment. So if the co-payment is $7, it should be at least $7. Now, the critics have said consistently, and that includes state government, state health ministers, including in my home state of Victoria, that it's just impractical to administer, or just hard and tough on doctors and medical hospital administrators. Now, I've been thinking about that, and one way that we could possibly do it is actually go the other way and look at it as similar to, say, an ambulance contribution scheme, where you pay an amount per year so that you can get access to free ambulance services when you need them. We could actually include emergency department services in that type of scheme. And that's just thinking laterally, which is what I think the states particularly are refusing to do at the moment.
Yeah, and on the PBS, I mean, there is already a co-payment scheme in place, but should that have gone higher, do you think? Do you think that should be more of a contribution from people who are using those medicines? So perhaps on the other end of the scale, you could have more medicines come onto the PBS as required.
Well, Laura, I think we have to look at the other side of this particular coin as well. That there have been a string of very important reforms to the pharmaceutical benefit scheme since John Howard in about 2004, under both governments, that have led to pharmaceuticals, prescription drugs being actually less expensive, not more expensive, and we have got more listings on the PBS as a result. In terms of the PBS co-payment, I think the issue is actually different to what you're suggesting. What I think is the problem here, and it's a challenge for the government, I think, and for the opposition to think about, is that we have a Medicare safety net for Medicare services and a pharmaceutical benefit scheme safety net for prescription medicines. I think the time has come where we have to think about the total impact of health costs on individuals and families and actually merge those two safety nets together. So I think that is far fairer to look at the total health costs, the total health impacts, than the way it is at the moment. But that takes a bit of policy courage, particularly from those in Canberra in the bureaucracy who have to put these things together. And we can't afford to be wusses about this. We actually have to bite a few structural reform bullets, of which this is just one.
Terry Barnes, we'll put some of your suggestions to the crossbench and Clive Palmer's senators over the next couple of days and seeing if they are willing to budge. Just quickly, how confident are you with changes? Do you think this Medicare co-payment will pass?
Well, I think that two of the incoming crossbench senators, Bob Day and David Leyonhjelm, have indicated that they will support the co-payment principle if the co-payment is lower. And I actually think if that is the price to pay to get it through, it is very important that the government considers that. In terms of Clive Palmer and his kennel of senators, I think his pups, if you like, I think it's important to make the case to them as convincingly and as powerfully as you can, and make the point that if it's done correctly, this is a fair and reasonable approach. Now, I don't think the government has actually sold it particularly well so far. The opportunity, though, is to reboot their selling effort and to tweak the package and not be too stubborn in resisting pressure to change it if the ultimate goal is to get the principle of co-payment and particularly user pays through the Parliament.
Okay, Terry Barnes, we will see and be watching very closely over the next couple of weeks and months. Thanks so much for joining us on PM Agenda this afternoon.
Thanks very much, Laura.
And after the break, we'll check in with our other Sky News presenters, Paul